All right, we have diseases and conditions of the circulatory system. Get us to our first slide here. All right, so first slide, we have orderly function of the circulatory system. So the cardiac cycle, this should be familiar from anatomy and physiology or medical terminology. So we know that we have the heart, and we have the arteries, veins, capillaries. Arteries always carry blood away from the heart. Veins carry blood towards the heart, and capillaries are the site of gas exchange. And this is just showing you here the arterial side. Capillary is where you see purple, and then blue would be the venous side. So the heart is a two-sided pump. Remember, the right side of the heart receives blood from the body, pumps blood to the lungs to pick up oxygen, drop off carbon dioxide. Blood then returns to the left side of the heart and is oxygenated, and then is pumped out of the body, out of the heart to the body. And this is just showing you here the blood flow. And remember, the left and right pulmonary arteries are they're going away from the heart, so they are arteries, but they carry deoxygenated blood. And then the pulmonary, right and left pulmonary veins are carrying blood to the heart, but it is oxygenated blood. And this is the only place in the body where that happens. All right, this is just showing the different layers. We have a double layered pericardium, which has a serous fluid. And what that does is it helps reduce friction. You wouldn't want two layers rubbing together. That would cause friction. And then we have a smooth endocardium so that the blood flows through without cells getting stuck. All right, and this is just showing you those structures of the smooth endocardium, the myocardium, which is the heart muscle, and then the pericardium and the pericardial cavity. Next, we have coronary arteries. So remember, the coronary arteries supply the blood to the heart muscle, to the myocardium. If there is an occlusion, which I'll show you in a few minutes, then that would be a myocardial infarction. So if the higher up it is, the more of the heart it's going to damage. The lower down, let's say the occlusion is here, it's only going to affect this part of the heart. Whereas here, it would affect all of this section here being supplied blood. All right, cardiovascular diseases. If you'll remember from med term, tachycardia means abnormally fast heart rate. Bradycardia means abnormally slow. Then we have cardiovascular disease examples. So angina pectoris, myocardial infarction or a heart attack, congestive heart failure, cardiac arrest, shock, and cardiac tamponade. Symptoms of cardiovascular disease, chest pain, dyspnea, tachypnea, palpitations, cyanosis, edema, fatigue, syncope. And then we have coronary artery disease. So this is generally, we have narrowing by atherosclerotic deposits, so plaque deposits, and then ischemia develops. So ischemia means there's narrowing, whereas infarction means that it's occluded, there's no blood flow at all. So causes of coronary artery disease, fat deposits, atherosclerosis, also arteriosclerosis, which is associated with older people and diabetics. Then we have risk factors for coronary artery disease. Genetic predisposition of the disease, which we know plays the biggest part in any disease process. People over the age of 40, men, a slightly higher risk factor than women, although women, the numbers are coming up, and women are at high risk of heart disease as well. Postmenopausal women, Caucasians, history of smoking, residence in an urban society, hypertension. And then here we have pain of angina pectoris, which would be a symptom. Severe pain of myocardial infarction is described as burning, squeezing, crushing, or radiating generally to the left arm, neck, or jaw. And nausea, vomiting, and weakness. These are classic symptoms generally for men, but women do not always present with classic symptoms. All right, treatment. Restore adequate blood flow to the myocardium. Vasodilators and other meds are used, angioplasty, and drug therapy. So here's showing you the catheter here with the angioplasty. So what they're going to do is there's narrowing here. So they thread the catheter through, inflate the balloon. You can only do this if there's space. If this is completely occluded, you can't do it. they're going to inflate the balloon and basically squishes all these plaques to the side, increases the lumen size, so more blood can get through. Now, if this person doesn't change their diet and their lifestyle, they can just develop it all over again. So they have to follow a strict diet. They need to exercise, walking, those types of things, and see their cardiologist. All right, this is showing you bypass grafts. So if you've ever heard of somebody having a coronary bypass or bypass surgery, this is what we're doing here. If the occlusion is here, what they're doing is stripping a vein out of the arm or the leg, attaching it to the aorta, bypassing the occlusion, hence the name, bypass, and putting it below the area of the occlusion. Now we can restore blood flow to this area. Okay, and we name it, basically, this person would have a triple bypass. 1, 2, 3. If there was another one, they'd have a quadruple. If there was only 2, they'd have a double. So we name it based on how many bypasses they have. So these are the bypass grafts. So chest pain with angina pectoris is due to ischemia, and that's usually with any type of exertion. And so there's reduced oxygen to the myocardium. And then atherosclerosis causes the narrowing. Symptoms: sudden onset of left-sided chest pain, and they may have pain into the arm or the back, which we call referred pain. Dyspnea, blood pressure may increase, and arrhythmias may occur as well. All right, so here are symptoms. We have the pain into the neck, the chest, the arm, and into the back. Diagnosis of angina pectoris: the patient history. They'll have pain with exertion. EKG is taken. And then other diagnostic measures such as coronary artery disease for coronary artery disease are performed. Myocardial infarction is death of the myocardial tissue caused by the development of ischemia. So now we don't have the just decrease in blood flow now. Now that it's stopped. So there's been so much ischemia, it's so narrow that now no blood is going through at all. So insufficient oxygen supply through the coronary arteries to the heart muscle causes coronary muscle death or myocardial tissue death. So coronary thrombosis is the most common cause of an MI. All right, so here we have the different types of myocardial infarctions. So if it's in the front, we would call it anterior. So here we have an anterior MI, and if it's lateral, that's to the side. Septal, this is the septum, and then inferior, we'd be on the back side. All right, symptoms: sudden severe substernal or left-sided chest pain, crushing causing a feeling of massive constriction, burning, and vague discomfort. And again, for women having an MI, just like with coronary artery disease, they may not have the full classic symptoms like men. It may be that they have heartburn or a little shortness of breath, or, women can present with classic symptoms, but it's not as common as men. Irregular heartbeat, dyspnea, and diaphoresis. And so this is showing you a coronary occlusion. So all this area past the occlusion is where the infarction occurs. So this is pretty high. If it was down really low, it would only affect this small portion. Not that that's not bad, but it doesn't affect as much as the heart as this occlusion does. All right, so diagnosis: history, chest pain, what happened, EKG, chest X-ray, and then laboratory tests, and those will reveal cardiac enzyme levels that have increased. And then, so these change in the enzyme level indicate death of the cardiac tissue. So these are some of the tests: the CPK, LDH, and the AST, and then also the troponin. So treatment for an MI is oxygen, morphine for pain, aspirin, vasodilation, so they give them nitroglycerin, which causes the vessel lumen size to increase, lidocaine, and then the standard of care is to try to emergently open the artery with a stent. Like I showed you, they use the balloon, and they put a little cage on it and open it up. So, and then here is showing you some of the graphs again. All right, and then here we have the stent. So we're putting in the catheter here. Stent is positioned, and that's this little cage. The balloon is inflated, and then the stent stays in place to keep this kind of pushed to the sides. All right. So, cardiac arrest, sudden unexpected cessation of cardiac activity. The patient is unresponsive with no respiratory effort and no palpable pulse. The results from anoxia. So, this is absence of oxygen to the tissue or interruption of the electrical stimuli to the heart. So, immediate intervention is needed. So, CPR and an AED. And it would follow the recommendations by the American Heart Association or American Red Cross. So this would be a 911 situation. Treatment of cardiac arrest, CPR must be instituted within 4 to 6 minutes because now the brain is going without oxygen. If not, cardiac defibrillation, ambulance or other medical personnel, and cardiac drugs, epinephrine, isoprenoterol, and dobutamine. Cardiopulmonary resuscitation, so that would be the rules kind of change with that. And so people in healthcare should have a CPR card, a healthcare provider CPR card. Therapeutic hypothermia. So recent studies have shown that cooling the body, a select group of patients immediately following cardiac arrest can improve neurologic outcome and quite possibly decrease mortality. So we want to improve the neurologic outcome. The longer they go without oxygen, of course, the more brain tissue will be damaged. All right. All right, then we have hypertensive heart disease. So most prevalent cardiovascular disorder in the United States, probably most closely related to obesity and also diet. So result of chronically elevated pressure through the vascular system, atherosclerosis, arteriosclerosis, renal disease, and any condition that creates increased vascular pressure cause the heart to work harder. And as it pumps against the walls, there's increased resistance. Essential hypertension basically has no symptoms. It's abnormally high blood pressure in the arterial system. If the person does have symptoms, they're vague: headache, nosebleed, lightheadedness, tired, and those are kind of vague symptoms that people don't really associate with hypertension. So essential hypertension has an insidious onset, which means that there's not really anything that shows until the damage has occurred. So the hypertension generally is detected when blood pressure is taken during a physical exam. So risk factors for essential hypertension: stress, age, heredity, smoking, obesity, sedentary lifestyle, poor dietary habits, and hyperactive personality or type A personality. So, what are symptoms? Headache, epistaxis, which is a nosebleed, lightheadedness, syncope, sometimes no symptoms at all. The hypertension generally is detected through the examination and is more common with increased age in all groups. So, diagnosis is made by taking a blood pressure reading, doing a physical exam, and taking a medical history, and then a laboratory evaluation. They'll do a general chemistry panel, and then usually a kidney function test. All right, so systolic reading of greater than 140 millimeters of mercury, and that's a systolic, and then a diastolic reading of greater than 90 millimeters of mercury indicates hypertension. So they've established recent guidelines that systolic reading of 120 to 140 indicates borderline hypertension. And they'll take a series of blood pressure readings. They're not going to just diagnose it based on one. All right, treatment, drug therapy, diuretics reduce circulating blood volume. When you decrease the blood volume, you decrease the pressure. And so that you reduce the fluid, reduce the pressure. ACE inhibitors cause vasodilation and increase renal blood flow. And then we have vasodilators that also dilate the blood vessels. Calcium channel blockers, they slow the heart rate down and reduce conduction, irritability, and also dilate the vessels. All right, treatment of essential hypertension. So the World Health Agency and the Cochrane collaboration with the U.S. guidelines promote a low-dose thiazide diuretic as the first line of treatment. So a thiazide diuretic is a specific type of diuretic. There's different categories. There's potassium sparing, non-potassium sparing. And so depending on the patient, really the therapy has to be designed to fit each patient. All right, malignant hypertension. This is a life-threatening condition. It's a severe form of hypertension. The symptoms would be a severe headache. This would be rapid onset, blurred vision, dyspnea, and Extreme stress is thought to be a contributing factor to malignant hypertension. Treatment. Aggressive intervention. If the person is not treated, they will die. So they need IV vasodilators, so diazide, sodium nitroprusside, which will open up the vessels and increase blood flow. Um, and by opening and vasodilating, it reduces the blood pressure because it's just like a pipe. If the pipe's narrow, there's more pressure. If the pipe is wide, there's less pressure. In severe cases, the systolic pressure reading may be greater than 200 and the diastolic pressure greater than 120. So after the condition is under control, blood pressure should be monitored on a regular basis, and the patient should continue drug therapy for life. Congestive heart failure. So there's right and left-sided congestive heart failure. It can be acute or chronic. Some causes of chronic congestive heart failure are hypertension, coronary artery disease, chronic obstructive pulmonary disease, cardiac valve damage, arrhythmias, and cardiomyopathy. So symptoms of congestive heart failure. Dyspnea, which increases gradually, cardiac and respiratory rates increase, anxiety, neck vein distension, edema in the ankles, and liver and spleen enlargement. And here is just showing you some of those same areas. So enlarged heart, pulmonary congestion, hepatic congestion. It really depends on if it's right-sided heart failure or left-sided heart failure. Okay, right-sided heart failure will back up into the body, so it causes the distended neck veins, the enlarged liver, and abdominal edema and edema in the legs and feet. Left-sided failure causes issues with pulmonary congestion because remember, if we're backflowing from the right side, it backflows into the body. If we backflow from the left side, it backflows into the lungs. All right, so a person with, when we're trying to diagnose congestive heart failure, then we need a thorough history and physical exam. We're going to listen to their heart and lungs. The films of the chest indicate presence of fluid in the lungs. We would do an EKG as well, and then also possibly catheterization. So this is showing the diagnosis of congestive heart failure. The lung fields here should be black. There should not be all this white stuff in here. That is the congestion, the pulmonary congestion. So treatment would be ACE inhibitors and ARBs to increase blood flow, diuretics to help reduce the volume of fluid in the body, vasodilators to help reduce vascular pressure, and other drug therapies. Cor pulmonale is known as right-sided heart failure, so enlargement of the right ventricle, and then the symptoms, like I mentioned before, it backs up into the body. There will be shortness of breath, distended neck veins, edema in the extremities, and an enlarged liver, also abdominal edema. So the diagnosis, again, history, physical, history of pulmonary disease. Keep in mind, if there's problems with the lungs, the patient generally develops problem with the heart. If there's problems with the heart, the patient may develop problems with the lungs. All right, so radiographic chest studies, echocardiography, and then an EKG. ECG, EKG, same thing. Treatment, bronchodilators, supplemental oxygen, bed rest, digitalis, diuretics, and then anticoagulants, and then in some cases phlebotomy, which means bloodletting. All right, pulmonary edema continued. Here we have condition of fluid shift into the extravascular spaces of the lungs. So we see pulmonary edema with heart failure. Symptoms include dyspnea, so difficulty or shortness of breath, coughing, orthopnea, increased cardiac and respiratory rates, and bloody frothy sputum. Remember, orthopnea means dyspnea when supine or lying down. All right, causes of pulmonary edema: left-sided heart failure, mitral valve disease, pulmonary embolus, systemic hypertension, arrhythmias, renal failure, head trauma, drug overdose, and high altitudes. Treatment of pulmonary edema, the patient is placed in the Fowler's position, so sitting and then given oxygen therapy. The reason they're sitting up is because if they lie down, they feel like they're drowning. Drug therapy, diuretics to improve fluid excretion. We want to get rid of as much fluid as possible safely. IV vasodilators, morphine sulfate, and then beta adrenergic drugs to dilate the bronchioles and control bronchial spasms. Cardiomyopathy. This is a non-inflammatory disease of the cardiac muscle, causes enlargement of the myocardium and ventricular dysfunction. There's three different groups and types of cardiomyopathy. There's dilated, hypertrophic, and restrictive. So with dilated, there's degeneration of the myocardial fibers. With hypertrophic, there's small left ventricle. And then with restrictive, there's thickening of the myocardium. So symptoms of cardiomyopathy: dyspnea, fatigue, tachycardia, palpitations, and chest pain. Treatment for cardiomyopathy is dilated cardiomyopathies. There's the therapy, anti-arrhythmic agents, digitalis, anticoagulant drugs. We're going to limit some of the activities: bed rest, beta adrenergic blockers, and ACE inhibitors. Pericarditis. So peri, we're talking about around. Acute or chronic inflammation of the pericardium, the sac that encloses and protects the heart. So consequence of inflammation or infection somewhere else in the body, and may occur also secondary to a myocardial infarction. So this is pericarditis. This does not look normal. This is very inflamed pericardium. So here we have a couple of things here: decreased output to the body, decreased blood flow. These are all things that can happen here. Fluid around the heart compresses the heart wall. The heart cannot expand to fill, backs up into systemic circulation, leads to that decreased output and decreased blood flow to the lungs. So this pericardium is inflamed and is squeezing. Symptoms of pericarditis: fever, malaise, chest pain, dyspnea, chills, and tachycardia. And then the treatment would be therapy. If it's infectious, antibiotic therapy, surgical drainage, aspiration, bed rest, analgesics, antipyretics, and non-steroidal anti-inflammatory drugs, or what we call NSAIDs. Myocarditis is inflammation of the muscular walls of the heart, may be associated also with a myocardial infarction. Symptoms include palpitations, fatigue, dyspnea. And with myocarditis, what types of infections commonly cause myocarditis? We have viral, bacterial, fungal, or protozoal infections, and they can also be a complication of other diseases such as influenza, diphtheria, mumps, and rheumatic fever. There are also can also be caused by exposure to certain toxic agents like lithium, the use of cocaine, alcoholism, radiation, and chemical poisoning can also cause inflammation of the myocardium. And a physical examination may reveal fever, arrhythmia, and tenderness in the chest. Treatment: if it's an infection, we're going to treat that appropriately with the right anti-infective medication. Rest, reduce the heart's workload, analgesics, anti-inflammatory agents, ACE inhibitors, and oxygen. Endocarditis, inflammation of the lining and the valves of the heart. Symptoms include fever, chills, night sweats, weakness, anorexia, and fatigue. So endocarditis is usually secondary to an infection from somewhere else in the body. So, and it can also be the result of a pre-existing heart disease or a consequence of abnormal immunologic reaction. So it could also be related to autoimmune disorders. So the condition is where we develop vegetative growths on the cardiac valves, and they could be released into the bloodstream in form of an emboli. So we don't want growths on the valves that could then dislodge and or come off of the growth and go somewhere else into the body, like the brain or the coronary arteries or the lung or the kidneys or anywhere else. All right, so this is showing you endocarditis. These are the vegetations here. Here we have, this is the valve. It should not look like this. So it's all these are the growths on the valve. All right, so endocarditis, here's some causes. We have respiratory tract infection, dental infection, so oral hygiene is very important. People with poor oral hygiene have increased risk of developing heart issues and valvular issues like endocarditis. Urinary tract infections, it could also migrate, and then skin infections. Causes: bacteremia, Staphylococcus aureus, Group A, beta hemolytic streptococcus, which causes strep throat. E. coli, Escherichia coli, which causes most urinary tract infections. Septic emboli from endocarditis can be carried by the arterial circulation and be embedded in major organs, resulting in infarcts and new places of bacterial infections. Diagnosis of endocarditis, they're going to do a CBC and a SED rate, or ESR, erythrocyte sedimentation rate, and the CBC may indicate leukocytosis. Also going to do blood cultures, an echocardiogram, or ultrasound of the heart, and an EKG. Rheumatic fever is systemic inflammation and an autoimmune disease involving the joints and cardiac tissue. It generally is preceded by sore throat caused by group A beta hemolytic streptococcus. And the antibodies then attack the body's own cells and initiate an inflammatory reaction. So symptoms of rheumatic fever. We have fever, polyarthritis, edema, redness, limited range of motion, carditis, cardiac murmurs, cardiomegaly, and congestive heart failure. History of an upper respiratory tract infection may also be present. Presence of carditis and polyarthritis, streptococcal antibody levels, anti-streptolysin O titer is elevated, and increased cardiac enzyme levels and white blood cell count and SED rate. After the diagnosis of streptococcal pharyngitis, which precedes rheumatic fever, treatment with a complete course of antibiotics prevents the onset of the fever and subsequent rheumatic disease. The administration of antibiotic penicillin is necessary to eradicate the streptococcal infection. So antipyretics are given for fever, anti-inflammatory agents are given to relieve the pain associated with the arthritic symptoms. So rheumatic heart disease, cardiac manifestations that follow rheumatic fever, dyspnea, tachypnea, edema, non-productive cough, and cardiac murmurs. So this is just showing some areas here, the valves that can be affected. So we have the pulmonary valve, tricuspid valve, aortic valve, and the mitral valve. And this is showing some of the, this is showing mitral valve prolapse. All right, so here's showing rheumatic heart disease. Here's one of the valves. I can't tell really. This might be tricuspid. It might have 3 cusps. It's kind of hard to tell because of the inflammation. But this is not a normal looking valve. All right, treatment of rheumatic heart disease. Surgery to relieve the stenosis or replace the valve. Good dental hygiene to prevent gingival infection. And prophylactic antibiotics are given to patients before any dental procedures. Valvular heart disease. Can be acquired or congenital disorder, and it can affect any of the 4 valves of the heart. It can occur in the form of either insufficiency or stenosis, and the diagnosis requires an EKG, radiographic chest studies, echocardiogram, and cardiac catheterization. The treatment usually is going to be administration of digitalis or quinidine for arrhythmias and antibiotic prophylaxis. Here we have first is mitral stenosis. This is hardening of the cusps of the mitral valve that prevents a complete and normal opening for passage of blood from the left atrium into the left ventricle. So it's stenosed. So symptoms would include dyspnea, fatigue, cough, and palpitations followed by hemoptysis. So coughing or spitting up of blood. Then we have the treatment. So limitation of sodium intake, diuretics, surgical intervention, and then valve replacement. Mitral insufficiency. This is when the mitral valve fails to close properly and completely and allows blood from the left ventricle to go back up into the left atrium. We do not want this to happen. We want the left ventricle to completely empty into the aorta. We do not want backflow. So symptoms would be dyspnea, fatigue, and heart murmur. Diagnosis would be through patient history, physical exam, an echocardiogram, an EKG, radiographic chest films, and then cardiac catheterization. Treatment, bed rest, oxygen therapy, antibiotics, surgical repair, and replacement of the valve. Mitral valve prolapse occurs when one or more of the cusps of the mitral valve protrude back into the left atrium during ventricular contraction. This is usually benign, and it can be caused by abnormally long or short chordae tendineae. Those hold the valve, the cusps. And when you listen to mitral valve prolapse, it sounds like a swishing sound. Symptoms of MVP, chest pain, dyspnea, dizziness, fatigue, syncope, and severe anxiety. Diagnosis, typically the click murmur syndrome is heard and a swishing sound. Echocardiogram confirms the failure of the valve to close, and then premature ventricular contractions, or what we call PVCs, are detected on EKG, are not considered harmful, and are not an indication of insult to the myocardium. Arrhythmias, any deviation from the normal heartbeat, that is the normal sinus rhythm. Okay, so normal heartbeat is what we call NSR, or normal sinus rhythm. They're often called irregular heartbeats. They can arise from any disturbance in the normal conduction system of the heart. That can be from the SA node, or the pacemaker, the AV node, atrioventricular node, bundle branches, or Purkinje fibers. So here's your basic cycle here. We have SA node, which is located here in the right atrium, and the arterioventricular node here, which is at the base of the right atrium. And then we have the bundle of His, and the left and right bundle branches, and then the Purkinje fibers into the myocardium. Symptoms of an arrhythmia: palpitations, rapid heartbeat, skipped heartbeats, slow heart rate, syncope, and fatigue. Diagnosis is made through a 12-lead EKG, echocardiography, and also through Holter monitors, which is an ambulatory EKG, and then also through event monitors. Treatment: drug-induced arrhythmias usually resolve when when the patient stops taking the drug. We often give patients anticoagulants so that they don't get blood clots. Oxygen, catheters, pacemaker, and cardioverter or defibrillators if needed, if they're in fibrillation. Pacemakers and implantable cardioverter defibrillators, and if somebody needs a device, so if they need a pacemaker, that basically means they need a device in there to set the pace of their heart. A defibrillator or cardioverter, when the person goes into fibrillation, they have a defibrillator, it sends a little jolt and kind of resets. So it takes them out of fibrillation. So pacemaker helps to relieve symptoms of heart rhythm bradycardia disturbances. And then the implantable cardioverter defibrillators are used to treat tachyarrhythmias, rapid heartbeats, usually from things including coronary heart artery disease, myocardial infarction, or cardiomyopathy. Cardiac ablation. So patients with abnormal heart rhythms may be candidates for cardiac ablation. So drug therapy is usually attempted to correct the arrhythmia first. When there's little or no response, then cardiac ablation may be attempted. So it's performed by an electrophysiologist after he or she completes mapping of the heart's electrical system. So it's pretty involved. All right, shock. Here we have collapse of the cardiovascular system, including vasodilation and fluid shift, accompanied by inefficient cardiac output. So it's a life-threatening condition requiring the patient's immediate entry into the emergency medical system, so a 911 situation. Causes of shock can be anaphylaxis, hemorrhage, sepsis, respiratory distress, heart failure, neurologic failure, emotional catastrophe, and severe metabolic insult. So anaphylaxis would be an hyperallergic reaction. Hemorrhage, they're bleeding out. Sepsis would be from infection. Respiratory distress would involve the respiratory system. Heart failure, of course, involves the heart. Neurologic failure could be brain or spinal cord injury. Emotional catastrophe can be when someone witnesses something devastating. And then severe metabolic insult could be from being acidosis or alkalosis. All right, symptoms of shock. Inadequate perfusion of organs and tissues, pale, cold, and clammy. The patient will be pale, cold, and clammy. They'll have a rapid, weak, and thready pulse, rapid breathing, altered level of consciousness, dizziness, extreme thirst, and profuse sweating. Treatment. Because of the severity and rapid progression of shock, they need aggressive intervention. And so it's not like you wait around to see how they're going to be. They need aggressive treatment. So any visible bleeding is controlled, and surgical intervention may be needed to halt any internal bleeding. Vital signs need to be monitored, and volume replacement is instituted with IV fluids. Cardiogenic shock is inadequate output of blood by the heart, can be caused by any insult that disturbs the heart's ability to pump blood. So a myocardial infarction, severe heart failure, certain arrhythmias, or valve failures can lead to cardiogenic shock. Treatment of cardiogenic shock, general measures for shock along with the administration of medications that increase the efficiency of the myocardium and or affect the blood vessels. The blood supply to vital organs needs to be improved. Oxygen demands of the myocardial tissue must also be reduced. All right, cardiac tamponade, compression of the heart muscle and restriction of heart movement caused by blood or fluid trapped in the pericardial sac. So we talked about pericarditis. This is where we have fluid now surrounding, and so it results from an insult to the integrity of the vessel of the pericardium, allowing blood to fill into the pericardial space. So it's compressing the heart. So symptoms, sudden severe dyspnea, rapid falling blood pressure, pulse becomes weak, thready, and rapid, shock, cyanotic above the nipple line, so the upper chest and above, and level of consciousness falls. Treatment. They need to insert a needle into the pericardial space and withdraw or aspirate all the blood out. So surgery is usually indicated to repair the leak, and then prognosis varies depending upon the causative factor and the success of the intervention and the health status of the patient as well. All right, that was a big one, and that's only part one. So because I could not fit all of this into one to post for you, I had to break it into two. So I will post first part, this one, and then I will post part two for you as well.